quorum, but we're going to consider SB 851 first, and that's Brown's bill. So just whenever you're ready, Senator.
Thank you, Madam Chair, members of the committee. For the record, I'm Senator Justin Brown, representing the 16th District. I'm here today to present Senate Bill 851. Senate Bill 851 attempts to allow Missouri to have the same telehealth flexibilities that other states in the U.S. have. It allows for digital and computer-based questionnaires to be utilized for simple, low acuity cases. During the pandemic, hundreds of thousands of patients were seen through this platform without a single complaint or disciplinary action being sought. Currently, Missouri statute, telehealth is limited to phone or video conversation and a synchronous method. Senate Bill 851 would allow for a visit to be started via questionnaire and then sent to a provider for review. Nothing in this language takes away from the requirement that a physician's assistant, or nurse practitioner would review and make the diagnosis. The questionnaire simply states a process of information gathering for the provider. The language requires that the information be sufficient to provide information as to a medical interview as been performed in person. Thank you for this hearing today. I'm happy for any questions, but I do have the experts in the room behind me that could probably answer those questions better than I.
All right, thank you, Senator. Do we have anybody here to testify in favor? Or any questions? I'm so sorry. Senator Washington?
Hi, Senator. Is this substantially the same bill as from last year?
Yeah, there's a few changes, but it's exactly the same.
Okay, so the changes that we kind of discussed last year, are some of those in here?
Yes.
Okay. So we can talk offline. I'll clarify. Thank you.
Okay. Mm-hmm.
Thank you, Senator Washington. Any other? I'm just double checking this time. Doing a sweep. Anybody here to testify in favor of the bill? All right, proceed.
Thank you, Madam Chairman, members of the committee. Justin Alferman, registered lobbyist for SSM Health. We would like to go on record today in support of Senate Bill 851. Real quickly to clarify, this starting language was taken from the Senate committee substitute that left this committee 7-1 last session. So that was the starting point. So all of the committee amendments that were added in last session are contained in the bill. And if they are not, we will make sure that we get with your office and make sure that they are in. With me today is our Vice President of Digital Health for SSM Health, and I would like to turn it over to Aaron Powell to describe for you all how the adaptive questionnaire has worked in other states.
Thank you all for hearing me today. So I know there's always concern about, I think it's safety. Is this AI? How does this platform work? And that's what I kind of want to outline for everyone today, so there's a good understanding of kind of the intention and the functionality. First thing to be clear about as it relates to the adaptive questionnaire is that this is a questionnaire that was written by humans. It is actually an algorithm that was written by a group of physicians nationwide. So this is not AI. This is not machine learning. It is truly algorithms that have been developed by providers nationwide. They utilize best practice and utmost safety in making decisions around the adaptive questionnaires and what questions are to be asked. In the midst of COVID, so just a little bit in my background, I'm a nurse by training, been in the healthcare for over 25 years and have watched the evolution. Have become very passionate about access and how we deliver care in a different way than we have historically, knowing where we're going in healthcare and knowing that the shortage is, the enormity of the shortages we are going to see in providers across the nation is growing. And figuring out how we answer for that as a healthcare system is really at the forefront of everything we're doing from a strategy perspective. And there was a really passionate comment made, I think, in the last testimony, and someone that made the comment that we think people could die. The other side of that is that if we don't have access for our most chronically ill patients, for the sickest patients, those are the people who are actually going to suffer. So creating alternative modes of care that allow for the least sick patients and those patients that just need an episodic intervention of some sort. That's really how we are working to create greater access, to make sure that our most vulnerable populations have the access that they need for those in-person visits when needed. At no point was the intention that this would replace primary care. The primary care physician is vital to longevity and care of all patients. This is purely to create kind of a release valve, if you will. And it's also keeping in mind what patients and consumers are telling us they want from a convenience perspective. And, you know, we've been able to really create a very good balance between very, very convenient care and very, very safe care. Our care is monitored. All of our providers are overseen by physicians from within our organization. They also are accountable for the same kind of HEDIS measurements for any kind of clinical folks that are in here, any of the same quality metrics that our providers are held to in our medical groups and clinics. These providers are held, and that same is monitored. And I think it's important to note that we went live in 2019 with just the video visit portion, evolved into asynchronous, obviously out of necessity during the COVID period. And I can tell you, as a healthcare system, without the utilization, the ability to utilize this telehealth, we probably would have, the community probably would have caved. We wouldn't have been able to provide the fast, efficient care, get people to testing facilities, get people medications or sent to higher acuity facilities if needed, because it was just vital in managing that population of patients. I think it's also important to speak to the fact that in our 4-state region, we have had 0 events related to whether it was video visit or asynchronous care. We've had 0 harm events. So it's carefully thought through. It is evidence-based practice, and the one thing it is not is AI. So that's kind of my spiel. I'm open to as many questions as you all would like.
I appreciate the thorough explanation. I have just a quick question. Is there a standard best practice for some of the questionnaires where this is being adopted nationally?
Absolutely. So when I refer to evidence-based practice, those are the standards any provider uses when they're delivering care as evidence-based practice. So yes, that is what is utilized in creating the care protocols and kind of prescription protocols and otherwise.
Okay, thank you. Any questions for the witness? Senator Washington?
Hi, thank you for being here today. Can you remind me what other states have you worked with that have done this?
We are in Oklahoma, Southern Illinois, and Wisconsin as well.
Okay, and I want to step back a little bit to the questionnaire.
Yeah.
Is this just as thorough as a questionnaire when you go to a in-person primary care physician or whatever?
Absolutely.
Okay.
And in
And-
some ways, I say that it's almost more thorough because there's kind of no way to forget any of the questions, right? It's every question that every provider would want to ask. Sometimes we forget, and I can say that as a nurse, you forget, oh, I was going to ask them that, and I forgot. This is every question you would possibly want to ask.
And Senator, I know I did this a lot for the committee last session, but I would also offer it up again this year. We can walk you through both the provider and the patient side of these questionnaires, and you can take a test drive for yourself to see how this technology works and what a provider then sees on the back end whenever they are using an adaptive questionnaire as part of their checking.
And the main reason we need this is so that we can expand our ability to provide services, healthcare services throughout our state. Because we happen to be a state that lost a significant amount of rural,
Yes,
not just hospitals, but providers in general, right?
absolutely.
And so this would be a lower cost way.
Correct.
This is our lower cost road to getting to
Yes.
where we want to be, which is so everybody can have health care.
And it's affordable care that is accessible to anyone regardless of insurance. So you don't have to have insurance. For $39, you have the ability to be seen by a provider and have care initiated, absolutely. And that, in keeping with kind of our mission and values, was one of the things that really drove us, is how do we reach everybody? And, you know, this has allowed us to be able to do that.
All right, thank you. Thank you for being here.
One more question. Tell me a little bit about the platform. Is this something that's owned, or is third-party, proprietary? Tell me a little bit about that.
Yeah, so we work with a third-party vendor that creates the software.
Okay.
It is then deployed from our website on our platform. It's integrated with our EMR. So any visit information then is recorded into the patient's EMR, fully integrated. Their primary care provider is able to see that and see that they had a visit and everything that happened during that visit. It also gives us the ability to, if we see a patient that we say, hey, we can't provide you with care, we need to escalate, we've also then can get them in to see a provider within the organization, or escalate the care accordingly.
And you do that yourself, where you escalate the care? That's something based on the information that they provide?
Yes, the providers do, yes.
Okay, I appreciate that.
And to the proprietary nature of the technology, there are many different companies throughout the nation that supply this type of technology. You may be able to speak to that.
Yeah, absolutely. I think I'm sure, as everyone's aware here, that the tech space is absolutely booming, and especially in healthcare. So, you know, this is just a particular vendor that, you know, it's just kind of the engine that holds all of the information and helps us to be able to ask the appropriate questions.
Thank you. Appreciate it. Our chair is now here, so I don't know that we have enough to make a quorum yet. So we'll just stay in our subcommittee, but we'll go ahead and let you facilitate if you'd like. Any other testimony or questions for the witness?
No, I think, you know, just one other thing that I really want to impress upon the group is, I know that there is concerns, and it's a big topic of conversation nationwide, is when we talk about AI. And the one thing that this platform is not is AI. This is a human-built platform, questionnaire, and it is truly just an algorithm that is propelled by a computer system, if you will. There's no machine learning, there's no computerized based recommendations of care, none of that. It is purely provider decision driven.
I appreciate that. Do you have any questions? Okay. All right. Thank you for your testimony. Oh, we have a quorum now. So, okay.
We're going to go ahead and briefly move out of our subcommittee in order to begin our hearing and take roll. Madam Secretary, if you could please call the roll.
Senators Coleman,
Here.
Carter, Arthur, Gannon, Moon, Thompson Raider, Washington.
Here.
With 4 members present, we are able to continue our hearing, not just in the subcommittee. And we'll go ahead and hear anyone in opposition to Senate Bill 8. I'm sorry, still in favor, 851.
Madam Chair, Ray McCarty, President of Associated Industries in Missouri, want to go on record in support of this bill. I think the previous witness handled most of the questions, so I'm happy to answer any others.
Thank you, Ray. Anyone have any questions for this witness? Seeing none, next witness in support, please come forward.
Madam Chairwoman, members of the committee, Megan Travis Henderson on behalf of the Missouri Hospital Association. We're in favor of Senate Bill 851 because it increases access at an affordable rate in the state of Missouri. Happy to take any questions.
Any questions for this witness? Seeing none, thank you for your testimony.
Madam Chair, members of the committee, Alex Eaton representing Hims and Hers this morning. We would be happy to support Senate Bill 851. Appreciate the committee hearing the bill today. Happy to take any questions. I think Aaron and others did a great job presenting it, so really appreciate it and happy to, again, take questions.
Any questions for this witness? Senator Washington.
Hi, Mr. Eaton. I know initially him and hers had some concerns. Have you been able to discuss this year's
Yes,
bill, and they are okay with all of that?
correct. Yes.
Okay,
Yep.
thank you.
Thank you.
Thank you for your testimony. Anyone else here to testify in support of 851? Here in opposition, please come forward.
Good morning.
morning. Rich Aubuchon on behalf of the Missouri State Medical Association, Madam Chairman, members of the committee. Our question of concern is not in regard to the questionnaire itself. So the questionnaire is in fact the evolution of medicine in some regards. So having something as a tool to help provide you a healthcare option is good. Our concern focuses primarily not on the questionnaire itself, but rather its implementation. And our main concern is in regard to establishing the very first relationship with the patient, the first time you've ever seen or unseen them. That being the time that they use this questionnaire to seek health care through a system. So our main concern is in that this would be the only time that they've seen this person presenting for, or whatever it might be, and that be the establishment of their relationship is based upon the questionnaire. That said, this could be a wonderful tool for other options, and we can't simply say that this is a bad tool, and that's not the point. It's that it shouldn't be the primary way that you actually see the patient for the first time. A situation where they have been in care with that particular provider, whether it be a nurse practitioner or a physician. That person that presents using a questionnaire might actually help funnel and triage that issue for them. And this is part of an office environment that we see every day where they present their things that they say that are happening, their symptoms. But for that to not have some relationship with that person prior to the physician or the nurse practitioner seeing that person, I think that's a concern for us. It's a valid one, and I think that we've worked with the sponsor and with SSM, the advocates for the piece of legislation. This is no surprise for them that we're opposed to the bill on that condition only.
I have a quick question for you.
Yes.
How would that be different than when you book an appointment and you show up into an office and you're handed a clipboard and you're asked to fill out a piece of questionnaire before you're seen?
It's not. It's just that what we're saying is that if that's the only time you've ever seen this person, in fact, you may not actually see them. You may just witness them.
That happens all the time, right? When
Right.
we go to the doctor, you make an appointment. I've never seen the
Absolutely.
physician. I've never seen even a nurse or any medical professional, and you have to fill out that form before you come back after making the appointment. So are you concerned about that practice as well?
So if what I'm following you is that no one sees you for that, I mean, that would be a concern.
I mean, that happens all the time, right? You show up to the office and you're handed a clipboard before you come back. All you've done is make an appointment over the phone, and they don't see you until you fill out all the disclosures and people,
But eventually, our main push is they see you at some point in time, that they put you in visible, touch and feel and do all the things that a doctor needs to do, or a nurse practitioner to make that appointment, a valid one. If we're talking about a scenario where they simply fill out a form and then they don't see anyone, that's a concern.
Okay. Any other questions for this witness, Senator Carter?
Just for the benefit of everyone here, we didn't catch who you represent. Can you?
The Missouri State Medical Association.
Okay, thank you.
Senator Moon.
Thank you, Madam Chairwoman. Mr. Aubuchon, I think
Good morning.
I see what you're saying there. I know that just the question that was asked, I've gone through that experience where you arrive at a doctor's office, especially if it's the first time you're going to complete a health history. Oftentimes what I write on a health history is not complete. And so the physician or the nurse might see something in person that would be valuable. Even though this bill is not going as far as I'm thinking it might, there are times, I believe, where telehealth is being utilized, and the resolution on the monitor may not be accurate. And so there can be some big misdiagnosis there. So I know this bill's not referring to that, but I think it is a starting point beyond that. If, as you said, the doctor or the practitioner is not actually seeing the patient after these things are being completed, that could lead to problems. So maybe we can talk a little bit more about that, but I think that there is some more discussion that's necessary.
And I completely agree. And frankly, the integration of technology in providing medicine to provide it as cheaply as possible, while also providing quality health care, I think is important. We're not against the integration of technology in regard to that, to the practice of medicine. We just want to make sure that it's not the primary time that they actually see that patient, the only time.
Any other questions for this witness? Seeing none, thank you for your testimony. Anyone else in opposition, please come forward.
Madam Chair and members of the committee, Brian Burnskater here on behalf of the Missouri Academy of Family Physicians. Want to go on record in opposition to the bill. Certainly want to echo the sentiments that Mr. Abshan made about that first contact. Just in general, our family physicians are very supportive of telehealth. Honestly, we have a lot of conversations about how well it's worked for our patients and how much we've appreciated the use. But just like any sort of technological advancements, there are bridges that go too far. And we feel like having this adaptive questionnaire count as a patient-physician relationship is one of those instances. I did present to the committee a couple articles just for your all's benefit, talking a little bit about, that kind of spell out some of these concerns. One was happened in the Wall Street Journal. A young man from Lynn, Missouri, was 17 years old, accessed an online platform called Cerebral, got access to antidepressants and ended up dying. He had a bad reaction to that medicine. Now, obviously, that platform should have caught the fact that he was not old enough to make those decisions, but it didn't. And so I just point that out to say that when you're having interactions with a platform versus a person, you obviously can more easily manipulate the system. And then the other one I put into the mix is an article from Thomson Reuters detailing the expansion of telehealth during the pandemic came with significant risks. The Office of Inspector General with the Department of Health and Senior Services has pointed out that there's potential fraud in some of these programs, and they're looking into it very heavily. So put those before the record, and I'm happy to answer any questions.
Thank you. Any other questions or any questions for this witness? Seeing none.
Thank you.
Anyone else here in opposition, please come forward.
Good morning. My name is Ryan DeBoof. I am a registered lobbyist for the Missouri Association of Osteopathic Physicians and Surgeons. Here in opposition to the bill, I would reiterate the concerns expressed by my colleagues. This bill paints with a fairly broad stroke, and there are some implementations that are perfectly appropriate in terms of, moving from an environment where you're filling out a questionnaire on paper in an office in a telemedicine environment using an online questionnaire. That seems like a perfectly rational thing. The concern does become what happens after that. And in some ways, I think some of the most concerning parts in the bill are where we talk about removing the requirement of dialogue to an exchange. And because that exchange, now we have the actual prescription environment happening through, chat, not through telemedicine, traditional telemedicine with a visual observation of a patient. And this begins to heighten the concerns around a lot of these situations. Happy to answer any questions.
Thank you for your testimony. Are there any questions for this witness? Seeing none. Anyone else here in opposition? Last call. Anyone here for informational purposes only? Seeing none, that will conclude our hearing on Senate Bill 851. A little note of housekeeping. Senator Razer, Senator Carter, and I are needed in another committee to be able to vote on exec session, so I'm going to pass the gavel. Oh, and Senator Gannon. Okay, so Senator Moon, I'm going to pass you the gavel for Senator Bean's hearing, and we'll continue so that we don't have to stop, but you're going to see most of the senators leave the room to go vote in another hearing, and then we'll come right back.
All righty. Senator Bean is here to present Senate Bill 874.
Mr. Chair, members of the committee as they leave. For the record, Jason Bean, State Senator for the 25th District, here to present Senate Bill 874. Senate Bill 874 repeals state law relating to hemp extract for the treatment of intractable epilepsy. Senate Bill 874 will repeal provisions about the state's hemp extract registration program, which is no longer being used. When the program began in 2014, it allowed qualifying intractable epilepsy patients to use hemp extract. Intractable epilepsy is also known as drug-resistant epilepsy and occurs when people have seizures that cannot be fully controlled by medication. 4 years after the hemp extract registration program started, the FDA approved a CBD oral solution aimed at treating these seizures. This new drug and the legalization of marijuana have led to there not being a single person using the hemp extract registration program, not one. Last year, legislation passed and became law that repealed the industrial hemp regulatory program in Missouri. Because of a drafting mistake, only 3 of the 4 sections it targeted were repealed. This left the remaining section about hemp extract registration program that I'm talking about here today. Senate Bill 874 would repeal the last section and officially put an end to the program. With that, I'd be happy to take any questions.
So, Senator, you're saying the program is now defunct and you're just removing it from statute?
It's all going through the federal regulations. We're just removing it. It's what we did last year. We just, through a drafting error in legislation, forgot to put that one.
Very good.
That's it.
Any additional questions from the committee? Seeing none, do we have anyone in support of Senate Bill 874?
Hello, everyone. My name is Ben Terrell. I am the Legislative Director for the Department of Health and Senior Services. I want to thank the committee for their time and Senator Bean for his time in presenting this bill. I really don't think I can say it any better than the Senator did, but this is a program that is now defunct with new advancements in medical technology. We've got FDA-approved drugs that are out there that can treat this. There is no need for this extract program. This is something that no growers are participating in. This is something that no patients are participating in. So this is just empty statute that is doing nothing any longer. We tried to get rid of it last year and missed it by about that much. So this shouldn't affect a single person. It's just trying to clean up statute.
Makes sense. Question for the witness. Seeing none, any additional witnesses in support?
Mr. Chairman, members of the committee, Ethan Thampe representing the Missouri Hemp Trade Association. Just wanted to provide a few more details, but I'll be brief. As the prior witnesses indicated, the FDA has approved Epidiolex, the CBD medication for these epileptic disorders. We now have the FDA on record as well saying that they're working with Congress presumptively through this next farm bill that should pass later this year to provide a regulatory pathway for the CBD and other cannabinoids on the market. So we just want to go on record in support and thank the Senator for this cleanup language, which is no longer necessary now that the federal government has taking full control of the regulatory aspects, both from clinical drugs as well as the widespread use of CBD and other cannabinoids in the market.
Questions for the witness? Seeing none, thank you for your testimony. Any other witnesses in favor? Senate Bill 874 in favor. Seeing none, any in opposition? Seeing none, for information? Seeing none, thank you, Senator.
Thank you.
All right, we'll go next to Senate Bill 1095. Senator Reagan.
Thank you, Mr. Chairman. Members of the committee, for the record, Senator Greg Razer, here presenting from the 7th District, presenting Senate Bill 1095. I have to be honest, I suspect the chair may want to be in the room or when I present this, as I'm amending language that she has included in the law.
I'll leave that to your judgment. She might want to be, so if you want to defer to another bill, that'd be fine.
I think the senator behind you may.
Senator McCreery, are you ready? Okay, let's go to Senate Bill 1326.
I want to be fair about that.
Thank you very much, Senator. Senate Bill 1326. Senator McCreery.
Thank you, Mr. Chair. Good morning, everybody. I'm Senator Tracy McCreery. I represent District 24 in St. Louis County. Thanks for hearing my bill this morning. As much as I dread when colleagues say this is a simple bill, this really is a simple bill brought to me by the Missouri Hospital Association. A few years ago, in 2021, I was in the House, but I did support the statewide telehealth network that was created for victims of sexual assault or survivors of sexual assault. And this bill in 2021 made changes to that framework. Under the legislation we're discussing this morning, a specialty hospital shall be exempt from the statewide telehealth network for purposes of forensic examinations for survivors of sexual assaults if the hospital has a policy for the transfer of a victim of sexual assault to an appropriate hospital with an emergency department. Quite simply, this language is seeking to make sure that survivors of sexual assault are being treated at appropriate hospitals that have adequate staff and equipment to care for their needs. Some hospitals don't have a 24-hour emergency room, so these patients would not be able to get the care that they need if they went at certain times of day. So with that, I'll take any questions.
So it sounds like you may have mentioned this, but in summary, if a specialty hospital is not really set up for these particular forensic exams, and that's the primary
It
reason.
is,
Okay.
and part of this, and there's someone here from the Hospital Association to explain it. When the hospitals get their licensure, there's a way that they can note that they provide general acute care. So we're just trying to do a little bit of cleanup.
Sounds good. Any questions for the witness? Seeing none, testimony in favor of Senate Bill 1326.
Mr. Chairman and members of the committee, Megan Travis Henderson on behalf of Missouri Hospital Association, here to support Senate Bill 1326. We'd like to thank the senator for her help. So essentially in 2020, legislation was passed that required sexual exams to be provided in all hospitals upon request. As the regulations have been drafted, we've realized that this is going to apply to every hospital, including those that don't have a standalone emergency department. So it's not the kind of place that you would think you were going to seek care. It's a psychiatric facility, a long-term acute care hospital, or an inpatient rehab hospital. So if you're thinking, I need to go to the hospital, that's not where you want to head. And so for those hospitals to be subject to the requirements, it's a lot of training for their staff, and it's also not where you want these exams to be done if someone does end up there. So the idea is that if they're one of these specialty hospitals, there's 25 in Missouri that are not DMH facilities. There's 6 DMH facilities that also don't have these ED departments as you would normally think of it. And so if someone shows up there by happenstance, they have to have a transfer agreement to an appropriate acute care hospital, and then they do not have to otherwise comply. So hopefully this will help patients get the right care in the right place and ensure that we have our staff in those facilities providing the care that they need to be providing that is not related to these sexual assault exams.
Very good. Thank you. Any questions for the witness? Seeing none, thank you for your
Thanks.
testimony. Any additional witnesses in favor of Senate Bill 1326?
Good morning, Chairman and members of the committee. Thank you very much for your time. My name is Matthew Huffman, and I'm the Chief Public Affairs Officer at the Missouri Coalition Against Domestic and Sexual Violence. We are a statewide membership association of more than 100 domestic and sexual violence service providers, and we are here to express support for Senate Bill 1326. Much like the senator has already said, and what we heard from our colleagues at the Missouri Hospital Association, we believe that this is really just cleaning up and clarifying the existing law. Part of what I wanted to touch on, though, is that by designating that hospitals which provide 24/7 emergency care as the appropriate provider of sexual assault forensic exams, it actually creates less confusion for both healthcare providers, victim advocates, and sexual assault survivors. And so this can benefit survivors and providers by creating consistency in law on who exactly has to comply with the Telesane program. This bill does not affect general telehealth services. It really is just specific to the Telesane network, and we very much support this effort. Happy to take any questions as well.
Thank you, sir. Any questions for the witness? Seeing none, thank you for your testimony. Any additional witnesses in favor of Senate Bill 1326? In favor? Seeing none. Any opposition to 1326? Any opposition? Seeing none. Any information to be provided? Seeing none. Thank you, Senator, for your testimony.
Thank you. Thank you, Senators.
And if it's okay with Senator, And the committee, we may just stand at ease for a few minutes, wait for the other committee members to return.
For those who weren't, I didn't have my microphone turned on. I just made a motion and there was a second to move into executive session. Okay, so I am now make a motion that we vote out due pass Senate Bill 801, introduced by Senator Fitzwater. This bill modifies provisions relating to child protection, including guardians ad litem and juvenile officers. Do I hear a second? Seconded. Any discussion on this? There is a committee substitute ending in .02C, which has been distributed in your packets, and I make a motion to adopt the committee substitute. Do I have a second? Senator Carter seconds. All those in favor of adopting the committee substitute say aye. Aye. Those opposed say nay. We have now adopted the substitute. I now move to vote Senate committee substitute for Senate Bill 801 due pass. Do I have a second? Thank you, Senator Gannon, for the second. Madam Secretary, if you could please call the roll.
Senators Coleman.
Aye.
Carter. I'll come back. Okay. Arthur. Gannon. Moon. Yes, sir. Do you want me to come back? Okay. Thompson Raider. Washington. So it's 4 to, you're a no, okay, okay, so it's 4 to 2.
Senate Bill 801 passes by a vote of 4 to 2. I now make a motion that we vote due pass Senate Bill 813, introduced by myself, modifying provisions related to inspections of certain long-term facilities. Do I have a second? Thank you, Senator Gannon. Senate Bill 813 is now before the committee. I now make a motion to vote due pass Senate Bill 813. Do I have a second? Senator Carter seconds. This is a roll call vote. Madam Secretary, please call the roll.
Senators Coleman.
Aye.
Carter. Arthur. Gannon. Moon. Thompson Raider. Washington.
No.
2, 3, 4, 5 to 1.
Hold on, I don't want to announce it yet.
Oh, I'm sorry.
That's no.
No, okay. So 5 to 2.
By your vote of 5 to 2, you voted due pass Senate Bill 813. I now make a motion that we bring up Senate Bill 899, introduced by Senator Black, modifying provisions related to child care provider licensing requirements for certain providers. Do I have a second? Senator Carter seconds. Thank you. There is a committee substitute ending in .02C, which was distributed in your packet. I make a motion to adopt the committee substitute. Do I have a second? All those in favor of adopting the committee substitute say aye. Aye. All those opposed, nay. The ayes have adopted the substitute. I now move to vote out Senate committee substitute for Senate Bill 899 due pass. Do I have a second? Thank you, Senator Gannon. Madam Secretary, please call the roll.
Senators Coleman.
Aye.
Carter. Arthur. Gannon. Moon. Thompson Raider. Washington. 7-0.
By your vote of 7-0, you have voted due pass Senate committee substitute for Senate Bill 899. I now make a motion that we vote out due pass Senate Bill 1111, introduced by Senator Black, creating a prescribed pediatric extended care facility license issued by the Department of Health and Senior Services. Do I have a second? Senator Gannon seconds. Senate Bill 1111 is now before the committee. I now make a motion to vote out Senate Bill 1111 due pass. Do I have a second? Senator Carter seconds. This is a roll call vote. Madam Secretary, please call the roll.
Senators Coleman.
Aye.
Carter. Arthur. Gannon. Moon. Thompson Raider. Washington. 6 to 1.
By your vote of 6-1, you have voted due pass Senate Bill 1111. And with that, I make a motion that we exit executive session and go back into committee to hear Senate Bill. That is the wrong committee. What's your number?
1095.
To hear Senate Bill 1095. Senator Razer, please come forward.
I know it's really hard. It's too early in the season.
You only the ones that move, like, then, okay. We're ready when you are.
Thank you, Madam Chair. For the record, Senator Greg Razer from the 7th District in Jackson County, here again to present Senate Bill 1095 to the committee. This is a bill that is frankly cleanup language from what I think and believe was an unintentional wording that is found in the trigger law that banned abortion in the state of Missouri. I believe when you look at this, it can quite easily be interpreted to have also included all forms of contraception being illegal in Missouri. And let me explain to you why that is. The definition within that trigger law, if you look on page 2, it's section 6, under gestational age, it says that the length of a pregnancy is measured from the first day of the woman's last menstrual period. That leaves out intercourse. So the first day of the woman's last menstrual period. So under that definition, I believe a woman is perpetually pregnant in the state of Missouri. If you go back to the first page, there are two definitions of abortion. The second definition is section B, and it defines abortion as the intentional termination of a pregnancy of a mother by using or prescribing any instrument, device, medicine, drug, or other means or substance with an intention other than to increase the probability of a live birth. So if you are a woman who is pregnant under the law, and if you take a birth control pill that is intended to not increase the likelihood of a live birth, have you not legally just committed an abortion under Missouri state law? If you have an IUD, if you have a morning after pill, if you are a sexual assault rape survivor. Legal experts I talked to make this argument pretty clearly, and a lot of these folks are providers, they're attorneys, health system providers, and this isn't theoretical. I had a major hospital system in my district go 2 days after this law was implemented where they stopped giving out Plan B to rape survivors. And those attorneys read the law and interpreted it the same way I'm presenting it. So what my bill would do, and there is a substitute, we made a small change to the bill, but it would just clarify that this is not intended to be construed to mean birth control. That's the crux of the bill. And I'm happy to take any questions.
Senator, thank you so much for being here. You and I have had significant conversations about this legislation, and we have a disagreement about the law as it's currently written. Are you familiar with the way that pregnancy is defined medically as always from the first day of a woman's last menstrual cycle?
That is how in the...
Not just statutorily, but that's the medical definition of pregnancy. So when a woman is expected to be pregnant for 40 weeks, it's always measured from the first day of her last menstrual cycle. Did you know that?
I'm not... Oh,
you didn't know?
As a gay man, no. I was not aware of that. I'm sorry.
So when I read this language, I think it's abundantly clear that contraception is currently legal in the state of Missouri. IVF is currently legal in the state of Missouri. The morning after pill, ectopic pregnancy care. I agreed to hear your bill because I don't think that there's any harm in providing clarification for that. But there are no hospital systems in the state of Missouri currently that are not offering those procedures. Every single major health provider in the state that previously provided those services is providing those services. And so I get it's a little bit of back to the future math when you talk about being pregnant before you're actually pregnant as the medical definition of pregnancy, and that can trip people up. I don't think that there's a downside in providing further clarification, but I also want to make it clear that it is abundantly clear currently using a medical definition of pregnancy that those things are legal in the state of Missouri right now.
And I would only push back on the fact that a very major hospital system in my district did read it that way, and for 2 days announced that they were no longer giving out Plan B. And it was after public pressure that they reversed that decision, but I think we agree.
Well, there was public comment from not just myself that said that that wasn't what the law said, but from DHSS, who publicly said that wasn't what the law said, as well as Colleen McNichols, who was the last abortion provider in the state for Planned Parenthood. So there was pretty uniform agreement, but I hear you. Are there any other questions?
Yes.
Ma'am.
Yeah, of course.
I think we do agree on this one fact, that if you're right and I'm wrong and we pass this, nothing has changed. But if I'm right and you're wrong on this, then we fix something. So.
Well, except that there is nothing that's currently not being provided in the state. And I think it's important for you to acknowledge that there is nothing that is today not being provided under the law as it's written.
Currently, providers are providing this with your interpretation of the law, correct?
Thanks. I appreciate that, Senator. Senator Washington?
Yeah, I wanted to make a comment and questions. One, I totally agree that it's not illegal. However, I disagree with you that there are no Madam Chair, that there are no providers who are not doing this, because there are. Secondly, I think that this is some proactive help, because before you got here, the number one reason that we came back for a special session in 2021 was to make sure that we could still have funding for, that if a woman wanted to get a abortifacient, a Plan B, that they could still do that. So there is a real threat to remove that as something that can be legal in the state. And secondly, on the ectopic pregnancy, there are countless attempts in the House to say that that is not a medical emergency, and there's not a full understanding that an ectopic pregnancy is currently, to this day, a danger to the woman. And there are physicians who will not even do that, and sending them to Kansas, where we live on the west side of the state, because they feel that they cannot do an abortion for an ectopic pregnancy, despite the fact there is nothing in the world that can save the woman or the embryo if it is in the tubes. It will kill both to try to carry it to term. So while I agree with you that there is nothing illegal right now about our reproductive health care and to take birth control, I do think that we have a real fear. And he mentioned it, although it's not part of this bill, we should have a fear for IVF as well, not only because of the Alabama ruling, but we actually have a federally appointed judge in this state that said she is against IVF when she was confirmed. So I think that these are some real threats, and I will disagree that that everybody is providing that. I think there are places where you can go and get it, but I do think that there is some fear on the part of our medical providers to not do some things because they are afraid of what may happen to them.
Senator, I tend to try to not get into exchanges when we're trying to have questions. We have a lot of time on the floor that we're able to talk about it, but I do just want to correct the record briefly. The federal judge that you're speaking about is a friend. What her statement at that hearing, which I was able to watch, was that she previously represented clients who had that position. And as a lawyer, you know that often
I don't think you know
we
the
have
person
lawyers.
I'm talking about, because I'm not talking about your friend in St. Louis, but thank you.
Okay. Any other questions for this witness, Senator Moon?
Just want to clarify, are there some of the drugs that you're referring to being used here also, do they also act as an abortifacient?
I don't believe so. I don't think so. We had this discussion, 3 years ago now? But it is clarified, and I apologize, I did not bring my glasses. It does clarify in here in the new language that this is intended to prevent, not to terminate.
The reason I ask is because we had House hearings where there was a Republican presented a bill not altogether similar, but there were some drugs that were listed in the formulary that was in the bill that acted as both. So I just wanted to clarify.
Yeah, this doesn't mention any specific drugs. It's more general, but it does specifically say to prevent.
Very good.
And I was very specific about that when drafting this. I don't want this to fall into an abortion debate.
Okay, thank you.
Are there any other questions for this witness? I'm sorry, for the senator. Forgive me, Senator. Thank you. Anyone here to testify in support, please come forward. Anyone here in support? Is there anyone here in opposition? Last call in opposition. Would anybody like to testify for informational purposes only? Senator Senator Thompson Rayner, would you like to have a question?
I would just like to make a comment. I think that there is some confusion on birth control in general across our state, and you know, I'm 100% pro-life and very much for our bills that we have on the books. But if we can have more clarity in our law for birth control, I think that it is a good idea, because we do have some who have mentioned to me that they felt birth control was a abortifacient, which it's not. And so if there is a way to clarify that, I think it is important. Thank you.
Thank you. Any other questions or comments? Senator Razer, do you have any closing comments?
Yes, and I just wanted to address ectopic pregnancies. It does add in here, you'll see that section is medical emergencies shall include but not be limited to ectopic pregnancies. So I know there are some confusions amongst medical providers about when they can act in that situation. So trying to clarify that for them as well.
Thank you, Senator. That will conclude our hearing on Senate Bill 1095 and our hearing on health and welfare.